Today's lecture, we're going to be discussing our generalized approach to chest pain in the emergency department, as well as hypertensive crisis and emergencies. Before we get started, I just wanted to review our ABCs of our generalized approach in the emergency department in regards to airway, breathing, circulation, disability, exposure, and environmental control, our fast exam, and our glucose, plus making sure we always do a urine pregnancy test in those childbearing women. So airway, really extremely important for your first approach. There's no point in, jumping to your fast exam if you don't have an airway. So ensuring that we have an airway that our patient is able to maintain. We may have trauma patients that may be in C-sign precautions, as you learned last week, really important to maintain that. Breathing and ventilation. So our patients may need to have oxygen. We may need to put patients on positive pressure ventilation, whether that's CPAP or BiPAP, or they may need more of a definitive airway. Always monitoring their pulse ox is going to be really important. Next is C, so circulation. So check those pulses. So do a primary survey, see if there's any evidence of extreme hemorrhage that we may need to control. Patients may need reversal of anticoagulant therapy, whether that be with Octaplex or vitamin K. And they may also need blood products as well. Disability, so this is where we're assessing for our patient's neurological status. So doing a primary survey evaluation, making sure you get your Glasgow coma scale, which we'll talk more about when we come to our altered mental status lecture. Exposure and environmental control. So this is not the time to be modest. So we really have to expose our patient and look at every part of them, because we may be missing a significant rash or trauma if we're not exposing those sites. So mnemonic, so armpits, breast, back, butt cheeks, and sac. Make sure you do a log roll and remove the backboard. All clothing should be removed completely. Important to expose your penetrating trauma first, and then think about controlling the environment. So trauma patients are prone to have hypothermia, so use those warming blankets to keep your patients warm, and you may also need warmed IV fluids for those patients as well. So last week we talked about the FAST exam. So this is our trauma ultrasound survey. So we're evaluating for pneumothoraxes and any pericardial effusion, and whether there's any intra-abdominal or pelvic hemorrhage that may be present. And then doing a finger stick. So sometimes patients may be presenting with altered mental status. It can be something as simple as a patient in hypoglycemia, which you can correct immediately, as well as always doing a urine pregnancy test in those patients who are childbearing years. So our lecture objectives. So obviously recognize emergent and non-emergent cases of chest pain. Really important to think about a broad differential and not just be thinking about cardiac chest pain, which is why we're approaching it from a common complaints versus organ system at this juncture in your education. So be able to describe the labs and imaging in order to evaluate those patients with chest pain. come up with your generalized management plan, identify those patients that may present with hypertensive crisis or emergencies. So today's lecture, we're going to be talking about just our basic approach to chest pain and what priorities we have in management. And we're really going to focus on what I call the big six of chest pain killers, and then some of the other common causes of chest pain. We'll discuss really important history, physical exam, and investigations that should take priority in those presenting with chest pain. We'll review some of the other causes of chest pain, and we'll certainly talk about hypertensive emergencies and urgencies. And then in our live lecture, we'll go through case studies of chest pain and hypertensive emergencies. So what are the big six? So these are some of the life-threatening causes of chest pain that you do not want to miss. So obviously acute coronary syndrome, so our STEMIs, our non-STEMIs, as well as our unstable anginas. And as you probably remember from ACLS, we're starting to have a new way of learning these. But we're not going to discuss it in this class because your pants will be all about the non-STEMIs, STEMIs, and unstable angina. So we'll continue going through this, but understand when you get to clinical, they may be talking about type 1, type 2 versus how we've previously categorized these. Aortic dissection and rupture, cardiac tamponade, pulmonary embolism, so we'll talk more about this in our shortness of breath lecture. Tension pneumo, again, this is going to be covered in the shortness of breath lecture, and then esophageal rupture. So we'll talk about our basic approach to chest pain and what our priorities are going to be. So let's first talk about somatic versus visceral pain. So as you know, one of the vitals that we'll talk about in emerge medicine that we tend not to think about as a vital is pain. And it's a really actually important vital sign, particularly in those patients presenting with chest pain. So somatic pain. So this pain tends to be really precise pain. They can localize it very well. Tends to be more of a sharp piercing pain, and this pain arises from the dermal pain fibers that enter the spinal cord at a single level. Visceral pain tends to be more poorly localized. It's definitely less distinct, and they may describe it more as a dull, aching, or pressure-like pain, and it arises from internal organ pain fibers that enter the spinal cord at different levels. The pain with the visceral organs can be referred to a number of different locations within the chest and abdomen. The patient may have more than one source of pain. And think about those elderly patients. So they often have serious illness, but they tend to present with more vague or nonspecific atypical type symptoms. So we typically classify their clinical presentation as not classic. So emerge medicine, like I love my Calgary guide. This is the Calgary Black Book, where they take common presentations and have this logarithm of differential diagnosis, which you should be thinking about. So when a patient is presenting with chest pain, we're not just thinking about cardiac chest pain, we should be thinking about multiple other organs as part of our differentials of chest pain. So this Calgary Black Book differentiates it as cardiovascular, pulmonary, and other. Within the cardiovascular, we really should be thinking of it as, do we have ischemic chest pain or non-ischemic chest pain, and the differentials within those. Our pulmonary chest pain, so there's vascular, there can be pleural processes, and our parenchyma. And we'll talk more about pulmonary chest pain in our shortness of breath lecture. Our other chest pain. So we should also be thinking about GI. So GERD is a really common presentation for chest pain in the emerge department. But pancreatitis, and another one of the big killers what we'll talk about is esophageal rupture or perforation. Think MSK, costochondritis is a really common cause of chest pain or some kind of trauma, rib fractures. Neurological or psychiatric, so anxiety is a common one, but again, this is going to be a diagnosis of exclusion. We want to work up chest pain appropriately. It could be dermatological, such as shingles presenting in a specific dermatome. So our management priorities in a chest pain patient, ABCs are always going to be your first step in management. Think about oxygen supplementation, may or may not require it. Establish IV access, so that's 2 large bore IVs, or you may have an ART line or a central line or an IO. Get these patients on a cardiac monitor and apply those defib pads in certain patients. Getting your O2 sats. Get that EKG. And again, star highlight, get that within the first 10 minutes. That's going to be critical. Think about blood work, so your cardiac enzymes, getting a CBC, comprehensive metabolic panel, our coag studies. Patients with significant chest pain, cardiac arrest will often have coagulopathies that we may need to manage. ABG, lactate. Patients might need blood products, so your type and screen and cross match. A portable chest x-ray. So again, we're not sending unstable patients to the x-ray department. And then our patients may need the cath lab. So this, again, remember from our cardiology, can be both diagnostic to determine the number of vessels occluded and the degree of occlusion, and possible treatment. So PCI, so putting in those stents. So approach each patient with chest pain as a possible life-threatening situation. I repeat, approach each patient with acute chest pain as a possible life-threatening situation. And if you have any doubt, important to err on the side of caution. Another good mnemonic I link here is OMI, so oxygen monitor IV access. So a resuscitation really should be prompted by any obvious distress, if we have abnormal vital signs, or a deep visceral type pain. So we're looking, we're listening, and we're checking. So what are we looking for? Airway. Look inside the mouth. Remove any obvious objects such as dentures. Listen. So we're listening for stridor, any gurgling that may imply that there could be airway compromised. Do suction under direct vision if you see that secretions are present. Do a jaw thrust, head, chin lift with C-spine precautions. Is our patient talking? So talking is a really good sign, but make sure you're looking for any signs of edema or blood or vomit or foreign body. Listen. So you're listening for any noise, which could mean obstruction. So we want our patient to be able to protect that airway. And if we have worry that our patient's not protecting the airway, definitive airway may be required at this point. Breathing. So look at the work of breathing. Do you see indrawing? Is your patient tripoding? Are they struggling for breath? In neonates and infants, do you see nasal flaring? Listen. So you're listening for those breath sounds and checking for your O2 stat, so pulse ox. Circulation, look. So what is your patient's mental status? The color of your patient is their central cyanosis. Feel. So you're feeling for peripheral pulses. You're checking heart rate, cardiac rhythm, as well as BP. Okay, so now we'll talk about the big 6 causes of chest pain. So the most important life-threatening causes of chest pain. So what are they? Cardiovascular, acute coronary syndrome, so cardiac arrest, STEMI, non-STEMI, unstable angina that could progress to STEMI. But again, in clinical, you may hear type 1 versus type 2. Aortic dissection and rupture. So these patients, if your patient has an aortic rupture, the likelihood of them making it from home to the ER, not likely. They exsanguinate really quite quickly. So we'll talk about that. Cardiac tamponade. So these patients are often in cardiogenic shock because the heart just isn't able to pump and fill. And then respiratory. So pulmonary embolism and tension pneumo. So we'll talk about those in the shortness of breath lecture. And then mediastinitis. So think about that esophageal rupture. Again, these patients are going to bleed out. So first, rule out emergent causes. So think 4 from cardiac. So acute coronary syndrome, dissection, tamponade, and here we also have Takotsubo. And then pulmonary is 2, pulmonary embolism, pneumothorax, and then esophagus is 2, rupture or impaction. So those are kind of the big killers, but there's other common causes of chest pain and why patients may present to the emerge department. So cardiovascular, pericarditis, myocarditis, endocarditis, and Takotsubo's cardiomyopathy. So we'll talk more about the 3 that are in red. Respiratory, so think infection. So patients with pneumonia may have chest pain or bronchitis. GI, so pancreatitis, biliary colic, GERD, super common, esophageal spasm, MSK, rib fractures or costochondritis, psych, so panic attack, anxiety. Again, this is a diagnosis of exclusion. We don't automatically look at a patient. Women, particularly young girls, tend to get lumped in, it's just anxiety. It takes no time to put EKG leads on and help our patients this way. And then derm, so shingles. So we'll talk now about history, physical exam, and investigation for our emerged patients presenting with chest pain. So history, so chest pain. So really important to ask the questions to give you a really good idea about the characteristics of the type of chest pain they're presenting with. So onset and duration. So was it sudden versus gradual? The duration, so how long has it been going on? So we know that is such a critical question when we're talking about angina versus STEMI or non-STEMI. Location and radiation, so where's the pain located? Does it radiate to the arm, back, jaw, abdomen? Gives us really good information. Are there any relieving factors such as position? So classic one is that pericarditis. I lean forward to help relieve that pain. Rest. So that helps us determine whether we're dealing with a stable or unstable angina, and any medication. So, our nitroglycerin. Associated symptoms, so shortness of breath, nausea, vomiting, cough, syncope, dizziness, diaphoresis, weakness, any focal neurological symptoms, and then any atypical symptoms. So really important to maintain a really high suspicion for acute coronary syndrome if you have women presenting with chest pain, elderly, and those diabetic patients, because they typically will have atypical presentation. So they're not going to come in with the same typical, I've got chest pain, it's radiating to my arm and my jaw. And our diabetic patients are going to be presenting a little bit younger because of the damage to the vessels that occurs with diabetes. And then don't forget to ask about drugs. So cocaine, could it be a coronary artery spasm that's driving the chest pain? Other really important history questions to ask. So any history of trauma? Was there use of medications or drugs before the pain began? Have they had previous episodes of pain that was similar, or has the pattern of their chest pain changed? Are there any risk factors? Any significant past or present illnesses? What medications are they on? Allergies, drugs, smoking, alcohol use, and then cocaine, I mentioned before. The pattern. So what do we mean by that pattern? So, coming on, chest pain coming on after climbing a few stairs, or after a few holes of golf where it previously wasn't a problem. Do we have any medical records, such as a recent EKG or stress test? Sometimes just picking up the phone, if we can get a hold of their family physician, we can get that information. And what are their cardiac risk factors? So hypertension, diabetes, cholesterol, family history, and then relative risks we should always be thinking about is age, male, postmenopausal women, obesity, and those with a sedentary lifestyle. Physical exam findings, so things that we are looking for. So patients who are diaphoretic, if they have apprehension or fear or sense of doom, pallor, cyanosis, anxiety. Are there any signs of DVT present or history of that? If there's JVD, pitting edema, look for the deviated trachea. What's the chest rise? So do we have bilateral versus unilateral? That'll give us information. Could I be potentially dealing with a pneumo? Is there a pulse deficit or a difference in systolic blood pressure? Listen for any murmurs. So murmurs are going to be a really good tool here. So is there mitral regurg? This could be because of a papillary muscle rupture from an MI, aortic regurg, or systolic ejection murmur. So really not uncommon in those elderly patients with significant aortic stenosis. Is there a friction rub? So again, we associate that with pericarditis. Is there muffled or distant heart sound? So I'm thinking tamponade. And what are the breath sounds? Are they absent or abnormal? We're palpating for any sub-Q air. So again, could I potentially have a pneumothorax? Are there any heaves or thrills present? Those specific physical exam findings in certain diagnoses. So if we're suspecting pulmonary embolism, so we're checking for evidence of DVT. Or are our patients hard to ventilate? So there could be an obstruction there caused by the clot. Heart failure exacerbation, or if we have a patient with a STEMI that's complicated by congestive heart failure. You're listening for any wetness of the lungs, so listen for crackles. Look for that pitting edema or hepatic congestion. Cardiac tamponade, think about, again, our Beck's triad, so hypotension, JVD, muffled heart sounds. Could they have a narrow pulse pressure, tachycardia, pulsus paradoxus, a pneumo, so decreased or absent breath sounds, or hyperresonance in one side of the chest. Tension pneumo, so look for that deviated trachea as well as instability. So when we're talking about hemodynamic compromise here, we're talking about low blood pressure, JVD, as well as tachycardia. So critical to get that EKG within the first 10 minutes of patients presenting with chest pain. So specifically, we're looking for any classic signs of PE, pericarditis with our diffuse ST elevation. Could there be electrical alternans indicating that there could be a large effusion present? And then, of course, we're looking for those ischemic changes. Do I have ST depression or ST elevation? So, but also remember that the EKG can either be completely normal or may only show nonspecific changes when our patient first presents, which is why it's really critical to get serial EKGs and see what's happening over time. So just a little reminder of what we see in EKGs in MIs as relating to the leads. And maybe now you guys will appreciate the Calgary guide. So when we're talking about the right coronary artery versus the left coronary artery, specifically what we're going to find in our EKGs. So this is a nice little chart on the differential diagnosis of ST segment elevation on EKG, differentiating STEMI and pericarditis. Our chart looking at the cardiac biomarkers over time. So always remember that the first one to peak is going to be your myoglobin, which tends to happen at the 2 to 4 hour mark. It peaks at 6 to 12 hours and it returns to baseline about 24 to 36 hours. I like to run this one in case my patients have had a reinfarct. If I'm just following the troponins, it can take up to 2 weeks for troponins to return to normal baseline. So I can't really follow if they've had a reinfarct or it was the original injury. The high sensitivity troponins nowadays are so sensitive that they're able to really differentiate now non-STEMIs and the unstable anginas, which used to have a very specific differentiation based on the cardiac markers being found. So a portable chest x-ray in emergency department, really important. So look for any evidence. So if you're suspecting a PE, there could be Westermarck sign, Hampton's hump. There may be pleural effusions present. If you're suspecting aortic dissection, look for that widened mediastinum. There could be a left pleural effusion. You may have trouble seeing a distinct aortic knob. For a tension pneumo, you're looking for a deep sulcus sign, a deep costeophrenic angle on the affected sign. Pneumomediastinum. You may see this in esophageal rupture as well as severe asthma. Looking for any evidence of parenchymal disease or rib fractures. So an early x-ray tends to be the top priority in the assessment and treatment of patients with acute MI, but it's critical if you're suspecting aortic dissection as kind of high up on your differential. So the chest x-ray should be done immediately in these patients to look for that widened mediastinum. In a patient with MI, the chest x-ray is usually normal, but it could certainly help confirm if there's any evidence of heart failure associated with that MI. Other diagnostics for chest pain. Think of your echo. So increasingly a bedside ultrasound, those pocket ultrasounds are being used in the emerge department. You can assess whether there's a pericardial effusion present, really see what that left ventricle is doing. Do you have a hypokinetic left ventricle, meaning you have a low ejection fraction that gives you information on that cardiac activity? Look for absence of lung sliding if you're suspecting a pneumothorax. Get your ABG, so look for signs of hypoxemia, hypercapnemia, or any acid-base abnormalities. Follow the lactate. D-dimer, again, be careful with this. It may be helpful to exclude DVT or PE from your differential if it's diagnostic, but understand, it's not all that helpful. And then don't forget about your cath lab for your STEMI. So again, this is both diagnostic as well as treatment. So the goal here is to send your patient within 90 minutes or kind of non-urgently for unstable or non-STEMI for determination of definitive diagnosis. So this gives us information on the number of vessels affected as well as the percent occlusion of those vessels. And then other labs, CBC, comprehensive metabolic panel, coag panel, type and screen, as well as cross-match. Now we're just going to give a basic review of some of the other causes of chest pain. So our cardiac causes of chest pain, so we're very well familiar with our acute coronary syndrome. So sudden cardiac death, we really covered that in ACLS. Our STEMIs, our non-STEMIs, and our unstable angina, aortic dissection and rupture. So red flags here. If we have a patient we're suspecting of this, if there's any neurological symptoms or if they're having abdominal pain in addition to the chest pain. Cardiac tamponade, so our Beck's triad of hypotension, muffled heart sounds, JVD. And then think about acute pericarditis, myocarditis, as well as Takotsubo cardiomyopathy. So some of our non-cardiac causes of chest pain, PE, we'll talk about that in our shortness of breath lecture. Tension pneumo, again, we'll cover that in shortness of breath. Esophageal rupture, these patients bleed out very quickly. And then some of our other non-cardiac causes, so costochondritis, varicella zoster, so aka shingles, panic attack. So we're not going to cover these. They were kind of discussed in ClinMed, BCM, as well as MSK. We'll start with our basic review of acute coronary syndrome. So as you remember, this is an acute obstruction of a coronary artery, and the severity is going to really depend on the degree and location of the obstruction. Patients can range from sudden cardiac death to STEMI to non-STEMI to unstable angina. Similar symptoms across the board: chest discomfort, pain. They may or may not have shortness of breath, nausea, diaphoresis. Our STEMI is our ST segment elevation myocardial infarction. This is the transmural MI. So we have myocardial necrosis with EKG changes. So we'll have those ST elevations that are not quickly reversed by nitroglycerin or may show a new left bundle branch block. So the new left bundle branch block used to be considered a STEMI equivalent. I still consider it that. The problem here on EKG with a new left bundle branch block, it could be hiding a STEMI. Our biochemical markers are going to be our troponin or CKMB. I always like to order myoglobin. It will really depend on your center and what they order. These are going to be elevated. These patients need to be reperfused immediately. So, the saying, time is heart muscle. So they need to be reperfused immediately. Our non-STEMI, non-ST segment elevation MI, this is a subendocardial MI. So we'll have myocardial necrosis without ST elevation. So here we'll have ST depression, T-wave inversion, or both. And we'll have elevated cardiac markers. So these patients really should be going to the cath lab as well for definitive diagnosis and treatment. It's just not as urgent. The issue here is they could be heading to a STEMI, which is why the new protocols that I don't know when it will be as far as testing, but the type 1 versus type 2. So we tend to send the non-STEMIs to the coronary care unit until they can be sent to the cath lab. But again, we're still treating with MONA, but we'll talk more about that when we get to treatment. And then unstable angina, it's treated just like a non-STEMI. So this is considered acute coronary insufficiency or a pre-infarction angina. So here you'll have no elevation in cardiac biomarkers, but what I will say is the troponins might not just be sensitive enough at this point. So it might be like an early non-STEMI. So it's defined as angina at prolonged rest, so kind of greater than 20 minutes. New onset significant angina or increasing angina. So whether it's more frequent, more severe, a longer duration, or lower in threshold of what would be causing the chest pain. So acute coronary syndrome, etiology, so acute thrombus in our coronary arteries that have significant plaque buildup. That plaque may become unstable or inflamed. It could rupture and split, and this is going to lead to exposure where the platelets are going to want to form a thrombus to heal that ruptured vessel. So the platelets get activated, and then we have the coagulation cascade leading to that clot formation. And then that clot formation can cause obstruction to blood flow to the heart muscle, which can lead to necrosis. And that's really going to be dependent on the amount of occlusion that's occurring. Less commonly, there can be a coronary artery embolism, a coronary spasm. So think about our Prince metal or our cocaine-induced artery spasms, or a spontaneous coronary artery dissection where blood is being diverted. Pathophysiology, so the severity is going to really depend on the size, the location of where the obstruction is occurring, and then the duration of the obstruction occlusion. And it can range from transient ischemia all the way to infarction. Myocardial dysfunction, so you can have ischemia but not infarcted tissue. So here you're going to have impaired contractility and relaxation, and it leads to hypokinetic or an akinetic segments of that vessel. And again, the size here is going to determine kind of the degree of the sequelae. So minimal, you might have mild heart failure, all the way to cardiogenic shock. Usually large parts of the heart muscle need to be ischemic in order to cause this kind of dysfunction. Myocardial infarction, so this is the heart muscle that's necrosed from reduction in the coronary blood flow to that specific part of the myocardium. The infarcted tissue is permanently dysfunctional, but there is a zone around that infarct that could potentially be reversible ischemia. And then infarction, again, the transmural versus the non-transmural, so our subendocardial. So the transmural is the whole thickness of the myocardium from the epicardium to the endocardium. And then the non-transmural, so the subendocardial, doesn't extend through the ventricular wall. And this is why we get that ST depression and T wave abnormalities. Patients may also have electrical dysfunction, and this can be significant in any of the forms of ACS. Ischemic and necrotic cells are incapable of conducting normal electrical activity. And so this can lead to a number of different EKG changes that you may see. Mostly it's going to be the T abnormalities, arrhythmias, or conduction disturbances. Acute coronary syndrome signs and symptoms may vary depending on the extent and location of the obstruction, but think about visceral pain, typical chest pain and radiation of pain. Often it's going to be accompanied by shortness of breath or diaphoresis, nausea, and vomiting. Some patients have silent MIs, meaning they have no idea that they've had an MI, and you may find after the fact pathological Q waves, and you ask them, oh, when did you have an MI? And they had no idea. But also think about the females, elderly, and diabetic patients presenting with atypical type symptoms. So diagnosis, really important to get that EKG within the first 10 minutes and do serial EKGs to see the evolution of the potential MI. Getting your serial cardiac biomarkers and then getting them to the cath lab as necessary within 90 minutes for a STEMI, and then non-urgently for a non-STEMI, unstable for definitive diagnosis. Our treatment of our STEMI, so pre-hospital care, oxygen, aspirin, nitrates, triage to the appropriate medical center, and then our drug therapy. So in addition to the aspirin, you want to get them on a second antiplatelet agent, anti-anginal medication, anticoagulant, and other meds in certain circumstances. So, those patients may need oxygen. And then the big one is the reperfusion therapy, getting the PCI within 90 minutes or urgent cabbage, or in those patients that you can't get to a PCI center, you may consider fibrolytics. And here's just some more physical exam findings associated with MI. And here's our investigations for MI. So think about C-reactive protein, what's going on with the white count, our cardiac bio markers, as well as what's happening with the EKG. So this slide is outlining the evolution of what's happening during an MI. And here you'll see that pathological Q wave that will often be on their EKG forever. And here's our outline of our management approach to MI. Our drug management priorities for STEMI. So, STEMIs are true medical emergencies. These patients are at extreme risk for conduction disorders and arrhythmias, and unfortunately include cardiac arrest. So the longer the time to revascularize, the more heart cells are going to die, and the risk for more electrical disturbances. So 12 lead needs to be obtained within the first 10 minutes of any patient presenting with significant cardiac symptoms, including chest pain or shortness of breath. Get the aspirin in, consider oxygen. So this, again, can be considered not appropriate. So there's really new evidence that suggests you may not want to give oxygen unless the O2 sats really dictate that. So the evidence is suggesting that the administration of oxygen will has the potential to lead to free radical development and can cause more myocardial damage. So you may or may not see oxygen being utilized, but something always to consider. Anticoagulant, so whether it's heparin, low molecular weight heparin, or fondaparinux, add a second antiplatelet agent in addition to your aspirin, so clopidogrel, nitroglycerin, morphine. Again, consider morphine. So it may not be required. So it tends to be used if the chest pain is severe and persistent, or they've maxed out the nitrate, or they're not able to tolerate nitrate for a number of reasons. Consider a statin. So my center tended to give the statin or optimizing their current statin to high intensity level statins, preferably before PCI. So again, it would really depend on your center, but always consider the statin. And then our reperfusion, whether it is PCI, CABG, or thrombolysis, fibrinolytics. Beta blocker, but this isn't given until 24 hours later. Always really important to consider the beta blocker, but it's not part of the initial workup, but I want you to be thinking about that beta blocker within the first 24 hours. And then really, really important star highlight is before these patients are discharged, getting them on an ACE inhibitor is going to be critical. And this helps prevent the patient from having myocardial remodeling, which is really important to try and prevent that remodeling. So reperfusion therapy, so CABG versus PCI, it really depends on really the severity, the number of vessels that are occluded, and the percent of occlusion of those vessels. So I like to say if LAD is involved, they're all going for CABG regardless. And if it's 3 vessel disease or more, they should have a CABG. Or if it's a diabetic patient and it's 2 vessel disease or more, they should have a CABG. Reperfusion therapy. So as we know, time is muscle. So thrombolytics, fibrinolytics. Primary objective is needle within 30 minutes of presentation on those eligible patients. So think about the contraindications for fibrinolytic therapy. So any patient who's had a history of hemorrhagic stroke or a recent stroke, if there's uncontrolled hypertension, if they've had a recent major surgery or internal bleeding, or certainly if you suspect aortic dissection. So the thrombolytics activate plasminogen in order to dissolve the clot. So it's indicated for acute infarcts with ST elevation. Time is going to be crucial here. So the demonstrated benefit of early treatment with thrombolytic therapy within the first hour or 2 hours after the onset of symptoms. Although you can give thrombolytic therapy up to 12 hours after symptom onset. So that means, if a patient is presenting 6 hours after the fact, you're not going to hold off on giving it to them, but you're going to have the best beneficial treatment effects if it's given early on. In the elderly, there's certainly a greater hazard associated with thrombolytic therapy in the early stages of treatment, and it's really determining, benefit outweighing the risk. So you're going to have to determine that. So complications of thrombolysis, stroke, so risk factors for intracranial hemorrhage, those patients over 65, body weight less than 70 kilograms, and then if we have a BP greater than 165 over 95 during admission. So some of our treatment exceptions for STEMI, so if it's cocaine-induced MI, you're giving oxygen, aspirin, a benzo, heparin, calcium channel blocker, nitro. So here we're not giving beta blockers, so that's going to cause unopposed alpha vasoconstriction. If you have a right ventricular, so an inferior wall MI, really need to be cautious with IV nitrates and morphine because this can cause an unsafe drop in preload. So these patients are really preload dependent. And then certainly Viagra use. We're not giving nitrates because, again, it drops the preload and these patients can get profoundly hypotensive. So our complications of acute MI, so arrhythmias, conduction disturbances, LV pump failure, mechanical defects, thromboembolism, as well as pericarditis, so Dressler syndrome. So this just outlines the complications associated, and it kind of explains the pathophysiology and the mechanism behind those. Aortic aneurysm and dissection. So as you remember from cardiology, aortic aneurysm is an abnormal dilatation and weakening of the aorta. It's most commonly found in white males greater than 65. The star highlight here is the smoking. The test question is always asking about screening. So all men greater than 65 with a smoking history need a one-time screening ultrasound to rule out. So if we rule out an aneurysm, they don't need to have serial ultrasounds. It's just a one-time screening. But if they did find an aneurysm, depending on the size, management is going to vary, whether they need ongoing serial ultrasounds to measure any growth in the size or whether they need immediate surgical intervention. Other risk factors: hypertension, hyperlipidemia, connective tissue disorders such as Marfan syndrome, infection if there's a family history. So complications of the aneurysm is going to be dissection, rupture, and they're certainly at risk also for increased thromboembolisms. So our AAA can be found incidentally on imaging or during a physical exam. A non-ruptured but symptomatic AAA may present as abdominal or flank pain, or they may also be presenting with thromboembolic events. Blood pressure management, really important to reduce the systolic blood pressure to about 100 to 120 while still maintaining organ perfusion. Beta blockage is usually contraindicated in these patients. These patients should be on pain control, so IV morphine is going to be important. And some patients can be discharged from the emerge department with a surgical referral for a AAA repair. So these patients, it's really critical that they're evaluated and cleared by the appropriate service, and that risk stratification has been performed prior to discharge, and documenting that is going to be critical as well. Okay, so aneurysms, as we remember from cardio, need to be surgically repaired when they get to the 5.5 centimeter size, or if we see that the aneurysm has been growing more than 0.5 centimeters within 6 months. As we remember, rupture has a really high mortality rate, and most patients get zero warning it's going to rupture, and unfortunately these patients exsanguinate on the way to the hospital. Symptoms tend to be severe back, abdominal, or flank pain. They'll be hypotensive and shocky, shortness of breath. They may have, if it's a thoracic aneurysm, a cough or vena cava syndrome. Treatment is going to be rapid assessment via bedside ultrasound, getting 2 large bore IVs in, and then our fluid resuscitation. So IV fluids and blood products. So my center, for every 4 packed red cells, we would give 2 units of FFP, 1 pack of platelet pheresis, and 1 unit of cryo. Consider keeping your patients hypotensive. So again, my center, we like to keep them, under the 100 systolic BP. And that's important to protect the integrity of the vessel. Is the patient on antiplatelet therapy? So getting a history and knowing, whether your patient is on certain medications, because we may need to reverse that to help with the bleeding. Pain management, so IV morphine, and then the most critical thing is to get surgical consult, so vascular surgery down as quick as possible. So here's a Calgary guide on AAA clinical findings and complications. Unfortunately, death within minutes with a ruptured AAA. They bleed out very, very quickly. Here is an ultrasound image of a AAA with a thrombus on the right, and then a CT scan of a pretty significant one on the left. So this is a picture of a graft that's been placed by vascular surgery to that AAA. Aortic dissection. So this is a tear within the layer of the vessel, and so it creates this false lumen where the blood flow is being diverted inappropriately. This, just like the AAA, can also be rapidly fatal because they're certainly at risk of tamponading the vessel. So whatever organ may not be getting perfused, it can also lead to rupture as well. So dissections can be caused from trauma, hypertension, infection, so syphilis is a good one, connective tissue disorders, again, Marfan syndrome, risk of dissection, and then iatrogenic. So I've certainly seen my share of dissections that we've caused putting in stents and aortic balloon pumps, etc. So mortality from a dissection is about 1 to 5 per 100,000, but it could be higher due to under reporting. Early diagnosis tends to be difficult. So diagnosis here, again, is going to be time sensitive, and mortality is going to increase with each hour, reaching about 80% by 2 weeks if it's not repaired. So pathogenesis, complications, and clinical findings here. So our risk factors for dissection: hypertension, coronary artery disease, aneurysm, they've had previous cardiac surgery, our Marfan syndrome, bicuspid valve, if there's a family history of aortic aneurysm, cocaine use, any kind of thoracic trauma, and pregnancy. So 4 times more increase in the likelihood compared to non-pregnant women. So mortality from aortic dissection can occur in 4 ways. So we can have acute cardiac tamponade. There can be acute aortic insufficiency, aortic free rupture, and then end organ ischemia. So any organ can be affected depending on where that dissection is occurring. So the pathophysiology, normal aging can lead to degeneration of the aorta, and certainly those patients who are hypertensive can accelerate that process. So there's 2 classification symptoms here. I most commonly use the Stanford system, and it's classified by the site. So here's images of the sites of the dissection occurring and the system to classify it. Aortic dissection signs and symptoms. So really the classic textbook presentation is going to be a middle-aged male, past medical history. Maybe they've got a bicuspid aortic valve. They're presenting to emerge with sudden onset, maximal intensity, so a sharp tearing chest pain that radiates to the back. On physical exam, you note there's a lack of pulse within the upper extremity. So symptoms, tearing, ripping pain are going to be the stir highlights here. Migrating pain, sudden onset chest pain. They may have a focal neurological deficit. That is a red flag. Things are going in the wrong direction. Numbness, tingling, pain, or weakness in the extremities. They may have symptoms of congestive heart failure. History. So think about all those risk factors: hypertension, family history, connective tissue disease, bicuspid valve, cocaine use. Physical exam findings, so may be completely normal. So exam findings classically associated with thoracic aortic dissection may be present in less than a third of all cases. There could be a murmur, say aortic insufficiency or a regurg murmur. So this kind of indicates there could be unseating of that aortic valve. So they could be shocky, so hemorrhage from a ruptured aortic dissection, internal bleeding, or interpericardial rupture, cardiac tamponade, JVD, pulsus paradoxus, muffled heart sounds. They may have a grayish discoloration of the face. They could be hypo or hypotensive, syncope, prolonged unconsciousness. There could be a pulse deficit and BP difference between the 2 arms of at least 20 millimeters of mercury, and they may not be producing any urine as well. Say aortic dissection red flags, so chest pain with neurological features, abdominal pain, or ischemic symptoms to the lower extremities. Those are really red flag symptoms of aortic dissection. So aortic dissection diagnosis and treatment. So EKG may be normal or may show nonspecific ST and T wave abnormalities. There could be new Q waves, left ventricular hypertrophy. There could be AFib or other tachydysarrhythmias. They could have acute MI, so including STEMI. Chest x-ray, so here it's not necessarily reliable or could be non-specific, but it is helpful to rule out potential other causes of chest pain that could be on your differential, such as pneumonia. The majority will have abnormal chest findings. We'll have the classic abnormal findings of a widened mediastinum, widening of the aortic knob or there could be an abnormal contour of the aortic knob. There could be pleural effusions present, or calcium signs. So that could be a separation of calcification of the aortic knob. Our CT angio is going to be our imaging of choice. So this is going to be 100% specific and sensitive. Our TEE sensitivity is about 86 to 100% with specificity of 90 to 100. But our TEE does require special equipment, as well as patients are going to need to be sedated. MRI sensitivity 90 to 100%, specificity 94 to 98. But here we have limited availability, and it takes longer. Those patients that are unstable, like again, you're not sending out of the trauma base. So bedside echo is going to be your imaging of choice here. Labs, limited use, but helpful in determining severity. So if you have a patient that is anuric, you're looking for signs of AKA, or looking at liver enzymes, because the liver might have taken a hit following the lactate, as far as patients that are hypoperfusing. Type and screen with cross-match. So these patients are going to need to have blood on board here. Treatment is going to be operative intervention, so you need to have vascular surgery involved as soon as possible. So after the diagnosis, it's really about rate and BP control. So this is really critical in order to prevent any hypertension from causing more shearing forces against that vessel and causing it to dissect further. Pain management. So if the systolic BP is greater than 120, you may want to consider vasodilating agents. So my patients tended to be less than 90 systolic. And then really important to have close monitoring of not only the vital signs, but neurological status, as well as urine output. So images of dissection, so CT scan on the left, widened mediastinum, and distorted aortic knob on the right. So our approach to our aortic dissection, so immediate CT angiogram is going to be important, unless of course our patient is unstable. If unstable, we're doing a bedside echo. Consider early emergence surgical consult, or be able to transfer your patient immediately to a center that's got a vascular surgeon present. Circulation, so the goals here, heart rate of 60 to 80, keeping their systolic blood pressure less than 120. My center, it was less than 100. Consider putting in an art line. The art line gives us really good information on titration of our medications, and we can make a really accurate, quick decisions on titration. So if there's a BP discrepancy with the extremities, dose antihypertensive meds based on the extremity with the highest BP. Treatment, initial drug measures really to reduce the pulse pressure. So we're targeting with two drugs here. So a beta blocker and an antihypertensive medication. If it's a one-drug strategy, labetalol, giving a bolus and then a continuous infusion. Okay, so next we'll talk about cardiac. cardiac tamponade. So we remember it's a major complication of a pericardial effusion, which is basically accumulation of fluid or blood within the layers of the pericardium, and that leads to decrease both cardiac filling and cardiac output. So pathophysiology, we've got high interpericardial pressure that leads to a decrease in venous return, which leads to decreased diastolic ventricular filling and a decreased cardiac output, which can lead to hypotension and venous congestion. So symptoms here are going to be tachypnea, shortness of breath, hypotension, and shock. Signs will be hepatic congestion, hypotension, JVD, tachycardia, and pulsus paradoxus. So remember our Beck's triad of hypotension, JVD, and muffled heart sounds. Investigations, so EKG, you'll have low voltage and electrical alternans, and then echo, you'll have pericardial effusion and compression of those cardiac chambers. Treatment is going to be pericardiocentesis, so either it's an echo or an EKG guided pericardiocentesis, where you're taking a needle and withdrawing the fluid from the pericardial sac. You can do a pericardiectomy where you're actually placing a pericardial window where the fluid can drain. You want to avoid diuretics and vasodilators, as those decrease venous return. And so we already have an underfilled right ventricle and a decrease in left ventricle preload and cardiac output. And really important to treat the underlying cause, so whatever's driving the tamponade. So another image of tamponade. So our approach to our critical patient with cardiac tamponade, so initiate resuscitation with IV fluids, but you want to limit the volume. Inotropes, so you want to increase the contractility of the heart, and vasopressors as needed. Immediately performing your bedside echo and look for the signs of the tamponade, so large pericardial effusion, RV collapse, potential inferior vena cava, and severely depressed LV contraction. So you'll have a hypokinetic left ventricle. Perform pericardiocentesis in unstable patients or a pericardial window, which is either done in the OR or the cath lab or ICU, as where we did it. Monitor for and treat any life-threatening arrhythmias. So, these patients can have various bradycardias or tachyarrhythmias, and then consider need for mechanical circulatory support. So, early consult with cardiology or cardiac surgery or ECMO team. Our Calgary guide for pericardial effusion and tamponade, so the pathogenesis and clinical findings. Okay, moving outside of cardiology, chest pain issues into esophageal rupture. So overview, esophageal rupture can range from small perforations to a large esophageal rupture. Most common etiology is going to be iatrogenic, and it tends to be due to endoscopic interventions. So there's a triad for spontaneous rupture, and it will be present in about 50% of the patients, of vomiting, chest pain, and the presence of sub-Q emphysema, sub-Q air. Morbidity and mortality rates are really quite high, and they're directly related to delays in diagnosing esophageal rupture, as well as delay in management. Perforations diagnosed within the first 24 hours have the highest likelihood of survival. So how do we treat? Broad spectrum antibiotics, consult thoracic surgery, and ICU admission is going to be critical for these patients. So two classic presentations of esophageal rupture. One would be an iatrogenic esophageal rupture. So we have a 45-year-old presenting a few hours after having an upper endoscopy, presents with retrosternal chest pain and painful swallowing. Or you could have a 35-year-old with a history of alcohol abuse disorder, presents with retrosternal chest pain following a significant episode of vomiting. So this would be your Brohaver's syndrome of a spontaneous esophageal perforation. Some other signs and symptoms of esophageal perforation could be fever, shortness of breath, nausea and vomiting, difficulty swallowing, vomiting blood. Physical exam, so they may have be unstable from sepsis, so tachycardia and hypotensive. They may be hypoxic. There may be crepitus on the chest wall. So auscultate for any kind of sub-Q air that may be present, or decreased or absent breath sounds. Investigations, so CBC, comprehensive metabolic panel, type and screen, lactate, blood cultures. You may want to do an ABG as well. Imaging, so chest x-ray, look for a pseudomediastinum, left-sided pleural effusion, or a pneumo-widened mediastinum, or any kind of sub-Q air may be present. Treatment, so really close monitoring of vitals, getting thoracic surgery down, as well as an infectious disease consult's going to be important. Getting them on empiric antibiotic therapy, pain management, and antiemetics. PPI to help neutralize that acid environment, having these patients NPO, drainage and debridement of the fluid collections and infected tissues, and these patients are going to need ICU management. So back to the kind of non-cardiac killers of chest pain, Takotsubo cardiomyopathy, acute pericarditis, and myocarditis. So Takotsubo, as we remember, aka stress or broken heart syndrome. This is a transient regional systolic dysfunction of the left ventricle. So here we don't have any significant obstructive coronary artery disease or any evidence of plaque rupture, but when they present, it really truly does look like acute MI. But when we send them to the cath lab, we don't find any significant evidence of obstruction or occlusion of those coronary vessels or plaque rupture. What we do see is the left ventricle dysfunction and remodeling into that octopus pot shaped left ventricle, and that remodeling is due to a catecholamine surge, whether it's from physical or emotional stress or microvascular dysfunction, coronary artery spasm. Investigations, or EKG, you're going to have ST elevations. You'll have positive troponins. Echo, you'll have LV systolic dysfunction and apical left ventricle ballooning. And our coronary angiogram, again, no evidence of obstructive coronary artery disease or plaque rupture. Treatment here is really going to be supportive care, so beta blockers, ACE inhibitors, and anticoagulant in those with severe LV dysfunction. So in EMERGE, it really does mimic acute coronary syndrome. So really most of them are going to be treated as MI until we've ruled out acute coronary syndrome. Our Calgary Guide, Takotsubo cardiomyopathy, pathogenesis, as well as clinical findings. Pericarditis. So etiology, so it's usually secondary due to infection. So star highlight as your viruses here, but it could be immunological or other. So MI, post-cardiac surgery, also known as Dressler's syndrome. Classification is really according to the composition of the pericardial exudate. Pathogenesis, so again, various etiologies, but basically whatever the etiology is, we're leading to inflammation of the pericardium. So we'll have thickening of the pericardium, and then pericardial exudate, and that leads to rubbing of the parietal and visceral pericardium. That can lead to further inflammation and further exudate. Our symptoms are going to be pleuritic chest pain, so meaning it feels better when they're sitting forward and kind of dangling the heart, and worse on inspiration and when they're lying down. They may have fever and fatigue and dry cough. They may have symptoms of heart failure such as shortness of breath and fatigue. Our signs are going to be fever, tachycardia, muffled heart sounds. We may hear friction, rub, increased JVP, and there may be heart failure signs if there's any tamponade that could be present. Complications are going to be cardiac tamponade, pleural pericardial effusion, and if the pericarditis lasts more than 3 months, we can have chronic or constrictive pericarditis that's going to require surgery. So diagnosis on EKG, you're going to have the classic PR depressions and continuous ST elevations and tachycardia. Chest x-ray, there could potentially be pulmonary congestion present. Echo may have pericardial effusion present. Treatment, it's really about treating the underlying cause, anti-inflammatories such as NSAIDs or steroids, and analgesias. For Dressler syndrome, we prescribed colchicine. And our Calgary Guide for pathogenesis and clinical findings. Myocarditis, so viral and toxic. So myocarditis is inflammation of the heart muscle. It's characterized by myocyte necrosis. So here you're going to have positive troponins seen in about 35% of cases of myocarditis. There's two main etiologies. The first one being viral myocarditis. So most commonly it's going to be Coxsackie virus, but rhinovirus, influenza, parvovirus, B19, and corona. And it can either cause direct myocardial injury or can cause injury secondary to the autoimmune response, so our molecular mimicry here. So it leads to the heart kind of thickening and weakens, and it causes systolic heart failure. Our toxic myocarditis, so caused by chemotherapy, drugs, cocaine, alcohol, diuretics, antibiotics, snake venom, carbon monoxide poisoning. So this causes myocardial damage and inflammation that can be due to either hypersensitivity to the drugs or the direct toxic damage of the drug to the heart muscle. Clinical features, so some patients may be asymptomatic, but if they do have symptoms, they may have flu-like symptoms such as fever, fatigue, malaise. They could have left ventricular failure, so we might have shortness of breath, orthopnea, PND, cough, chest pain due to the myocarditis plus or minus pericarditis, and they may also have palpitations due to arrhythmias. Complications could be or cardiomyopathy, which could lead to heart failure, arrhythmias that could lead to sudden death, pericarditis that could lead to pericardial effusion and tamponade. Investigation, so EKG and continuous telemetry Serial troponins, so important to do it immediately, then 6 hours, then 24 hours. CBC, so you may have an increase in white count. CRP and SED rates can be elevated. Chest x-ray, you may have cardiomegaly. Echo, you could have dilated or poor ventricular function. Management is going to be bed rest, heart failure, triple therapy, so or an ACE inhibitor or an ARB, beta blocker plus a diuretic. Warfarin, so we want to be able to prevent thromboembolism, and then supported treatment, so fluids and analgesia, and really about treating the underlying cause if at all possible. So our myocarditis, pathogenesis, and clinical findings from our Calgary guide. Okay, now moving on to hypertensive emergencies and urgencies. So kind of definition, so hypertensive emergencies versus hypertensive urgency. So an acute and critical increase in blood pressure of greater than 180 over 120. So hypertensive emergencies, it's symptoms and or end organ damage with that kind of blood pressure. Presentation can involve stroke, MI, heart failure, renal dysfunction. Really important to not forget to look in the eyes for papilledema. BP should be lowered by about 25% within the first 1 to 2 hours. Careful and calculated decrease in blood pressure is important in order to avoid cerebral edema and watershed stroke. These patients should have ICU admission as well. Our hypertensive urgency, so they're going to have an increase in blood pressure, again, greater than 180 over 120, but they're not going to have any evidence of end organ damage. BP here should be lowered within 24 to 48 hours in order to avoid any potential end organ damage. These patients can often be treated with PO antihypertensives and discharged with really close outpatient monitoring. Suspicion for underlying causes such as CBA, hemorrhage, intracranial tumor, cerebral venous sinus thrombosis, etc., are going to really warrant a head CT. You may want to consider doing urine drugs screen as well, because there could be potential cocaine use driving that blood pressure. So our hypertensive urgencies, because they can be often treated with PO med, really important to verify their home meds. So patients often lose their meds, miss doses, they can't afford them, or they're just not compliant. And so you may find that restarting them on their home regime is often sufficient enough with close follow-up. So PO meds, clonidine, and there is some now questionable discussion on the use of clonidine in hypertensive emergencies. So I would kind of asterisk that. I wouldn't be surprised if they're still testing this on PANTS. Hydralazine, calcium channel blockers, or ACE inhibitors, ARBs, diuretics, long-acting nitrates. So patient education here. So med compliance is going to be really important. Salt restriction, quit smoking, and don't use cocaine. Our hypertensive emergency, so treatment goal here, IV antihypertensive used to rapidly decrease blood pressure, and PO antihypertensives are really started once we can wean them off of the IV antihypertensive. So medications, so our IV infusions and our IV push medications are listed. So here's a logarithm for acute treatment of a hypertensive crisis. And again, don't forget to look in patients' eyes presenting with that kind of blood pressure for papilledema. And here is our flow chart for patients presenting with chest pain. And any questions, please bring them to lecture and we'll discuss.